Welcome to a presentation on urinary health in continuing care settings. It is based on the best practices that are described in the provincial infection control document called Guidelines for the Prevention and Treatment of Urinary Tract Infections or UTIs in Continuing Care Settings. This presentation will focus on the importance of being able to correctly identify what is a urinary tract infection and what we can do to help prevent UTIs for our residents and clients. Urinary tract infections are the most common bacterial infections found in older adults. In the community, UTIs are the cause of 25% of bacterial infections in older adults, and in long-term care that number rises to 30% of all bacterial infections. We know that diagnosing a urinary tract infection in long-term care is difficult, and staff often rely on behavioral changes and urine dipsticks or multisticks to diagnose rather than looking for the real signs and symptoms of an infection. This often leads to misdiagnosis and unnecessary treatment with antibiotics. Overuse or inappropriate use of antibiotics leads to an increase in resistant organisms in both long-term care and the community, but it can also lead to harmful interactions with other drugs or cause unwanted side effects for our clients. Although we do see urinary tract infections on a regular basis, there are some practices that we need to improve and many questions that we hope to answer with this presentation, like how do we know when someone really has a UTI? When should we be contacting the primary caregiver about starting treatment? How do you get a proper urine specimen? What should we do when families insist on antibiotics for the resident when they may not have an infection? How can we reduce the number of urinary tract infections in our facilities? The objectives of this presentation will be to identify the difference between a real urinary tract infection and asymptomatic bacteriuria, which means bacteria in the urine with no signs or symptoms of infection. To be able to state 3 symptoms to look for when assessing for a urinary tract infection or a catheter-associated UTI or CAUTI, and be able to describe when and how to collect a proper urine specimen for culture and sensitivity, and to be able to describe practices that will help prevent or reduce the incidence of urinary tract infections. Age-related changes that make urinary tract infections more common in the elderly are changes in bladder function like urinary retention or incontinence. Having an intermittent or indwelling catheter makes you more likely to have a UTI. Being dehydrated or not receiving adequate fluids to flush out our bladders reduces the bladder's ability to get rid of the bacteria. Being on immunosuppressive drugs or having diabetes changes how your body copes with bacteria. Changes like a prolapse or loosening of pelvic muscles or organs in our bodies makes us more susceptible to infection. Anything that can cause a urinary tract obstruction or impairment, like an enlarged prostate, fecal impaction, or incontinence, affects our ability to fight off urinary tract infections. And finally, the practice of routinely testing urine, either by a dipstick or urinalysis, when there are no symptoms, makes UTIs more common in the elderly. Why do we test urine when there are no specific symptoms of a urinary tract infection? Here are a few common misconceptions people have regarding urinary tract infections. We think urine should be sterile and not have any bacteria in it, and if there is, it should be treated. We think cloudy or smelly urine is a sign of infection and should be tested and treated. We think that anytime there is a change in a person's thinking, behavior, or day-to-day abilities, it must be a urinary tract infection that we should treat. Sometimes people think that after someone has been on antibiotics for a urinary tract infection, the urine should be retested to make sure it worked. As our bodies age, our perineal muscles and pelvic organs start to sag. Because of this looseness, bacteria, especially from the rectal area, will get into the bladder and colonize it, especially if we are incontinent or need a lot of assistance with personal care, or if we have had a catheter at some point in time. A positive urine culture or dipstick without symptoms means the resident has asymptomatic bacteriuria, which means colonization exists in the bladder and not infection, so treatment is not required. Now that we know what asymptomatic bacteriuria is, and that if we do urine dipsticks or a culture and sensitivity test, we will get a false positive, let us look at who tends to have asymptomatic bacteriuria. Many studies have been done to come up with these statistics. In long-term care facilities in people over the age of 70, up to 50% of women will have it and 15 to 40% of men. In the community, we will see it as well, in the same age group, 11 to 16% of women and 4 to 19% of men. People with chronic or long-term catheters in both long-term care and the community have asymptomatic bacteriuria all the time. What can we do to identify when a real urinary tract infection is present? Look for typical signs and symptoms. We know this can be challenging because symptoms may be masked by medications they are on, other health problems, memory impairment, or difficulty with communication. Also, the resident may have chronic urinary problems like incontinence or frequency, so it may be difficult to tell if there is a real change. Classic symptoms like fever and pain in older adults may not present the same as they would in a younger person. You will need to know your client and use your clinical assessment skills to identify these changes. So what are the typical symptoms we should be looking for before doing further testing? For those residents without a catheter, you should have or meet at least one of these criteria: acute dysuria or painful urine, or acute pain, swelling, or tenderness of the testes, epididymis, or prostate, fever, which is a temperature of 37.8 degrees centigrade, or repeated oral temperature of greater than 37.2, or a single temperature greater than 1.1 over the baseline, or leukocytosis, which is an increased white blood cell count, and one of the following new or increased localized urinary symptoms, which are urgency, frequency, incontinence, suprapubic pain, costovertebral or flank pain, or tenderness or gross hematuria. Or if there is no fever, then at least two new or increasing urinary symptoms. For those with a catheter, the resident should have at least one of the following new or increasing symptoms: fever or rigors, which are shaking chills. Again, the fever can be a temperature of 37.8 or repeated oral temperatures of greater than 37.2, or a single temperature greater than 1.1 over the baseline. New onset hypotension with no other known or possible infection site. Leukocytosis, which is again the blood test, with no other infection site and either an acute change in mental status or an acute functional decline, purulent discharge from the catheter site, pain, swelling, or tenderness of the testes, epididymis, or prostate. Once you have documented symptoms, discuss your findings with your residence physician or nurse practitioner. Information that should be reviewed if the practitioner wants to prescribe an antibiotic will be any treatment limitations in the Advanced Care Directive, recent or current antibiotics the resident is on, medication allergies, creatinine clearance levels, and whether the resident is on warfarin, as it can interact with antibiotics. A culture and sensitivity test is usually necessary to see what organisms or organism may be causing the infection. If an antibiotic is prescribed, the culture and sensitivity will confirm whether the antibiotic is a good match. Ensure that the resident is well hydrated and monitor for worsening symptoms or improvement. Proper handling and labeling of the urine specimen will assist the lab in testing, reporting, and interpreting the culture and sensitivity results. To make sure you get the best results, urine must be collected before any antibiotic is given. Make sure your requisition has all the information needed to interpret the results. The correct resident information, history of symptoms, method of collection, name of the antibiotic the resident will be started on. Knowing the antibiotic will make it easier to do sensitivity testing, especially if it is an unusual antibiotic. The longer a catheter is in place, the more it is colonized or covered with multiple types of bacteria. If the catheter has been in place for less than 14 days, a specimen can be collected from a sampling port after it has been properly cleaned with an alcohol swab. If the catheter has been in place for 14 days or more, then you will need to remove the old catheter, insert a new one, and collect the specimen from the new catheter. That way, the bacteria you will find in the urine will be from the bladder and not a biofilm that has formed on the catheter. Bacteria in urine will start to multiply after 1 hour, which could result in an inaccurate report on the amount of bacteria in the resident's urine. Once collected, urine should be refrigerated if it is not sent within 30 minutes of collection. Urine should be transported in a cooler bag, again to prevent overgrowth of bacteria, and ideally it should get to the lab within 24 hours. I just wanted to mention that urine specimens should not be kept in a refrigerator with food or medications. Once the culture and sensitivity results are known, inform the practitioner so they can make sure the antibiotic is the most appropriate for the organisms that are identified. 20% of UTIs may be caused by more than one organism, and often these organisms have different sensitivities to antibiotics. If 3 or more organisms are found, then it is assumed that the specimen was contaminated and you may need to send another one. As mentioned previously, retesting after treatment is not needed unless symptoms persist. During treatment, it is important to continue to push fluids and monitor if the resident's symptoms are improving on the antibiotic therapy. Looking for symptoms of a urinary tract infection is not always easy. Residents may not be able to tell you what the problem is. You may only see that there are changes in what they can do and how they are behaving. As we've said before, this does not mean they have a urinary tract infection, but it means that you will need to work harder to find evidence as to what is causing the problem. Research tells us that waiting 24 hours to see if typical symptoms of a urinary tract infection develop will not increase the resident's illness. Unless the resident's health is deteriorating rapidly, you should monitor vital signs and symptoms to look for these more subtle changes. Review symptoms for other diagnoses like a respiratory, a gastrointestinal, or a skin infection. If there is a change in mental status, see if they may be constipated, are they having increased pain, are they dehydrated, are they passing their urine okay, any changes in their medications, dosage of medications, have there been any environmental triggers? Looking for these changes may be difficult to remember. To help you review these, we have developed a tool called ABCs for diagnosing urinary tract infection in continuing care. A stands for assessment, what you are looking for. B for bacteria, what you should see if they meet the criteria for a UTI in the culture and sensitivity test. C stands for a care plan to follow if the resident does not meet the criteria, but they are still unwell and need to be monitored. It also provides a care plan as to what to do if they do meet the criteria. Let's talk about what we can do to prevent urinary tract infections from happening. Adequate hydration and nutrition are very important. Promote activities that will increase fluid intake like fluid rounds, happy hours, tea times, and any time there is socializing happening. Those residents on fluid restrictions or thickened fluids need extra special attention to make sure that they are getting the amount of fluids that they can have. Try to figure out what types of fluids the residents like the most. Hot, cold, sour, sweet. Are there any cultural preferences? It's also important to promote healthy voiding habits. Schedule in regular toileting with privacy if at all possible. If they need assistance, offer toileting assist or reminders every 2 to 3 hours. Make sure that constipation and fecal impaction are prevented. Mobilizing the resident as much as they are able to tolerate will help maintain their toileting abilities. Promote good perineal care and hygiene. No one likes to sit in a wet incontinence pad, so they do need to be checked and changed regularly if used. Wash the perineal area from front to back with warm water and a mild or neutral soap. Avoid bubble baths and scented wipes as they can be very irritating to the perineal skin area. In summary, urinary tract infections are the most common bacterial infection in long-term care. Preventing UTIs should be part of the work we do every day. We also need to look at how we identify urinary tract infections, remembering that most elderly have bacteria in their urine most of the time. So do not use dipsticks or urinalysis to look for bacteria. Always look for symptoms first, then plan to send a culture and sensitivity urine to confirm what you have found. Antibiotics can cause problems even if you do need them, so make sure our residents get antibiotics for the right reasons. Just remember the street light. If there are no symptoms, think of a red light. Do not test the urine and do not treat. If there are vague symptoms or changes, go cautiously and think of the orange light. Assess and monitor the resident. Individualize the care you are providing to look for other causes or true signs and symptoms. And if there are symptoms, think of the green light. Contact your practitioner to test and treat as per your usual protocol. There are a few other educational tools that we have developed to go along with the guideline. One is a clinical education sheet about why we do not want to treat asymptomatic bacteriuria. It can be used as a way to introduce the change or as a visual reminder to clinicians about the myths and facts about urinary tract infections and why we need to change our practices. Another information sheet that we have developed is urinary tract infections and asymptomatic bacteriuria in continuing care. What is the difference and why it is important? Again, it highlights the difference between the two and why it is important not to overtreat. There is also a pamphlet that is for the focused on clients and their families or caregivers about when it is appropriate to receive an antibiotic. It can also be used as an educational tool. Thank you for your time today. If you have any questions or concerns about the information in this presentation, you can contact one of the 2 email addresses listed on the slide. All the information from today is based on the guidelines for the prevention and treatment of urinary tract infections in continuing care settings, and this guideline, as well as the tools talked about today, can be viewed at the Ministry of Health website, which is on the bottom of the page. Again, thank you for your time. The following 3 slides list the additional resources and sources of information that were used in the making of this PowerPoint plus the other ones involved with the guideline.